Jonathan, don't leave when we're done because I want a picture. I have to show my husband. Good morning. All right, you guys ready for endocrine? Is everybody ready for endocrine? All right. Okay, just as an FYI, endocrine is scary, but it doesn't need to be, because endocrine is all about fluids and electrolytes and imbalances. Okay, so if you think about it that way, everything we talk about today will be centered around some sort of imbalance. And then as we go through the day, I want you to think, what nursing action will I take? You guys are probably noticing a trend on your test. It's all about what action you'll take, correct? Yeah. So start thinking about it. I'm going to give you a lot of information, and what you're going to do is you're going to take it in your little brains and you go, so what does that mean? What do I care? Big deal. Once you start thinking about how it affects your patient and what would you do for them, okay? All right. So let's just talk about a little overview of the endocrine system. I know you had part of this in your med-surg course, correct? You guys went over it to some extent, but you didn't get into the critical care type stuff. So just a little reminder, the endocrine system works on a negative feedback system. Essentially, you put out a hormone, and then when your body says you have enough, it sends out another hormone to make it stop, or it sends out a signal to make it stop. So to me, that's a positive feedback loop, but they call it a negative feedback loop because essentially, when you have enough, it sends out the proverbial sign to make it stop. Okay. So no matter what happens in endocrine, if something needs to happen, it sends a signal. Once you have enough of it, it sends out another signal and tells it to stop. Okay? The big thing with the endocrine system, especially within the pituitary gland, is that really severe illness or something that happens real suddenly can actually kind of send your pituitary gland into kind of spasms, as you will, and it can actually make it where your pituitary gland doesn't work very well. So people that have chronic illness or who have had some sort of real sudden trauma or accident may have problems making all the hormones they need because they're just suddenly depleted. Okay? We're going to start off with DI. And did you cover this at all in med-surg? Briefly. Okay. Well, we're going to go. Okay. We're going to go a little deeper into it. Think of diabetes insipidus, and we call it DI for short, as kind of a disturbance in the force. DI messes with your ADH, which is your antidiuretic hormone. Now, ADH basically regulates your serum osmolality and your circulating blood volume. It's the one that when you start getting dehydrated, your body sends out a signal and says, oh, I may not have enough fluid. I should just probably not urinate anymore. Well, with DI, you're not making enough of the ADH, and you keep urinating, and you keep urinating, and you keep urinating until you're extremely dehydrated. Now, what happens when someone's extremely dehydrated? The electrolytes are out of balance. What signs and symptoms are you going to see? Signs and symptoms of shock. But yes, the first sign and symptom they're going to see is thirst. So anyway, I don't want to get ahead of myself. I'm really bad about that because I get so excited. Central DI comes straight from the pituitary. Now the pituitary is just right here behind your brain, or behind your nose, in the center of your forehead. So there's congenital reasons why people have DI. Any kind of midline brain malformation can cause DI. So children that are born with a malfunction called septo-optic dysplasia, it's just a midline malformation. Real severe cleft palates can cause DI, because think about it, that's a midline malformation, so it's messing with that pituitary. So there are actually quite a few congenital cases of DI out there. Your book says it's rare to have some of these, but actually it's not as rare as you think. So secondary reasons for DI is what you're going to see mostly in the adult world. That's anytime someone's had a real bad head trauma from an accident, or anything that caused swelling in the brain, say a brain tumor, or they've had some sort of surgery that might cause swelling in that area. That's when you're going to see a little bit more DI. Obviously, meningitis is severe inflammation in the brain, DI, because anytime you've got swelling, inflammation going on in there, you're going to mess with that pituitary. Now, you also have nephrogenic DI, and that's basically when the kidney is not responsive to the ADH. We don't mess with that a whole bunch in the endocrine system. They usually worry about that in renal. But remember we talked about how lithium can damage your kidneys? Lithium is one of the big culprits for causing DI nephrogenically. Go figure, huh? Now, psychogenic, that's just a mental disorder. They drink themselves silly. It goes in actually really well with your chapter on schizophrenia and psychosis and personality disorders. So it actually really goes in really well with this whole test, because not only is it in the endocrine system, but it's also in your psych stuff. So we have a lot of children who come in whose parents from day one have tried to keep them hydrated, so they give them a cup and they always have a sippy cup and they always have a sippy cup, and these kids are literally drinking themselves silly. And they think that they just have to always have a cup in their hand. And yes, you want to keep your kids hydrated. But if they're waking up 2 or 3 times at night and demanding water, and there's nothing wrong with them, it's time for the parents to step in and go, what was I doing? Maybe that wasn't a great idea. You know it's psychogenic, though, if they can actually sleep through the night. So sometimes they'll wake up, but if you can get them to sleep through the night without demanding water, it's probably psychogenic. Adults who do it psychogenically, again, mental health disorder, it goes in really well with everything you guys are studying. Now, how many people have drank so much alcohol that they peed their pants? Don't be lying, I know you have. Jonathan's like, okay, if you have a friend who ever drank too much and woke up in a puddle the next morning because they peed their pants, alcohol actually suppresses your secretion of ADH. And so it's not uncommon for someone who's really skunked to pee themselves. How do you fix that? Quit drinking. Yeah. Such an easy solution, right? Okay. So if you look at your signs and symptoms of DI, Sean Curry's right. The very first symptom that you're going to see is thirst. Okay? They're going to they're going to urinate so much. They're peeing out more than 200 mils an hour. If you ever have a patient who pees out more than 200 mils an hour, you need to watch them. And if they keep doing it for a couple of hours, you need to make some phone calls, especially if there was any sort of head injury or anything that would cause any swelling in the brain, because it means they've got too much pressure on their brain. Enuresis is that bedwetting. We like to use fancy words in here because this is nursing school. It just means bedwetting. Obviously, you're going to have your signs and symptoms of shock because you're urinating too much. So you're going to be tachycardic. You're going to have hypotension when you stand up. You're going to be really weak. You may have some nausea and vomiting. Why would you have nausea and vomiting? Because your electrolytes are off. Exactly. So think of this. If you're urinating too much, your electrolytes are going to be off. It's going to cause some issues. What are the first things you would see with someone whose electrolytes are off? Could you see that? Confusion, yes. Look for an alteration in their mental status. They're also going to start having cramps in their legs, the proverbial Charlie horse. Signs and symptoms of kind of twitchiness. But mostly what you're going to start to see is kind of just a little bit of a slow decline in their mentition. The labs are pretty important in this. The good part is that the multi-sticks, you can measure their urine with one of those multi-sticks. That is such a cheap and easy test. When they pee, the urine is going to look like water. It's going to be so dilute. It's going to be either really, really pale yellow or really, really just clear. The urine osmolality drops below 300. The specific gravity drops below 1020. Specific gravity is really important to detect DI, that and your sodium levels, because what happens when you don't have enough fluid? Your sodium levels go up because you don't have enough fluid in your system to dilute it within your cells. So you're going to see a low specific gravity, a high sodium. Okay? Now, if it's not just extremely obvious that is what is going on, and most of the time it's extremely obvious that this is what's going on, they will do a water deprivation test. Water deprivation tests are from hell. They're awful. They're awful. Because basically what you do is you bring someone in and they can drink all up until the moment they get to you. They can drink, they can eat, they can do whatever they want until the moment they get to you. And the moment they get to you, no fluids at all, no food because of the water that might be in the foods. They can't do anything. And every hour you're going to measure their weight, you're going to measure their blood pressure, their heart rate, and you're going to draw labs every hour. You're going to get a sodium, you're going to get an osmo, and then you're going to get a urine osmo and a urine sodium. At the beginning of the test, they also check an ADH, and they check it at the end of the test. This is 8 hours. Now, a grown-up might be a little grumpy. Doing this on a little kid, ugh. Actually, little kids are not so bad because they can be distracted, but teenage girls, they're the biggest whiners. Oh my word. Teenage boys pass out when you draw their blood. Teenage girls whine about not getting to eat and drink. Go figure. Anyway, you're monitoring every hour because if they really have DI, what are they at risk for? Shock. Exactly. If you see a drop of more than 5% in their body weight, you know that they're losing too much fluids. Now, in the comatose patient, this is where the nurse really becomes their advocate because the comatose patient can't tell you they're thirsty, right? So, the awake patient can say, I'm thirsty. The awake child will drink out of the toilet. I kid you not. I have seen kids vault over my desk to get to my water bottle
They were that thirsty. Yes?
Just with the specific gravity, the normal range is 1.005 to 1.030.
That is not the normal range.
That's what it says in the book.
The normal range is 10 to 10, no, it's 1020 to 1030, I think.
I just
Look it up in a lab book because that's not,
Okay.
1005 is not.
Okay.
Yeah, that's not right.
Okay.
And you know what? Somebody post that on the session so I can remember to answer that, or then we'll keep looking it up. But that is not the normal.
Yes, it's the normal specific gravity of your urine ranges from 1.005 to about 1.6630.
Okay, I can see where they're saying that range thing, but if we deprive you of water and you don't concentrate your urine in 8 hours to 1020, it's an issue. Does that make sense? Okay. Because if you've been out and you've been drinking a lot of fluids just because you're trying, who knows, it's summertime and you drink more, but you haven't been sweating it off, it wouldn't be unusual for your urine to be that dilute, but if we took your water away and we withheld it, then you should start concentrating that urine. So, all right, your DI patient that's comatose, they can't drink. They can't tell you they're thirsty. They can't give you any of the signs and symptoms that a normal person could give you. So you have to really watch that urine output. You have to monitor them for an imbalance in the electrolytes, which if they can't talk and they're comatose, you're going to start looking for signs and symptoms of seizures. You're going to be looking at their skin and assessing them for hydration, correct? Look at the mucous membranes. Check them for hydration. Check them for hydration. Check that urine output. You're going to see a decrease in their perfusion, so they may lose some of their pulses, or their pulses may become kind of weak. So you're going to assess their pulses. And then, of course, if you send off labs, they're going to have really severe hypernatremia. Okay? Obviously, if it progresses and it's not taken care of, they're going to go on into seizures and death. So it's kind of funny that I put loss of consciousness on the comatose patient. I'm brilliant. So how do you treat it? It's actually a pretty simple treatment. DDAVP is probably the #1 way to treat it. Now, DDAVP comes in 3 different types. It comes in a pill. If you have mild DI, the pill typically works. If you have moderate to severe DI, the pill's not very helpful. That's when you have to go. They have a nasal spray that's actually very hard to use, but once you learn it, it's not so bad. But essentially, this nasal spray has this tubing on the end of it, and you pull your dose up, and you put it in their nose, and then you blow on it, and it sends the dose up their nose. Not my favorite way to deliver it, but for at-home use, a lot of people don't mind it, because otherwise they have to give themselves an injection. The other way to give it is through an injection, obviously. And it's just a little sub-Q shot. Sub-Q shots aren't that bad, but some people have the needle phobias. So if they can do the nasal spray, that's what they'd much rather do. It is usually administered a couple times a day. For someone who can manage their fluids while they're awake, they might only need it at night. But again, for the patient who can't tell you what's going on and who can't drink, a couple times a day is probably what they're going to have. The big deal with the DDAVP is that it must be refrigerated. You order DDAVP and you go pick it up from the pharmacy and it's room temperature. And you're kind of frustrated. So it has to be refrigerated or it goes bad very quickly. You have to give the doses at the same time each day. If for some reason someone got diagnosed at 3 o'clock in the afternoon and they gave them that DDAVP, but you're getting it every 12 hours, well, it's not particularly convenient to get up at 3 a.m., right? So how can you get that schedule changed? Who said that?
Move it an hour each day.
Perfect. Move it an hour each day. So one day go to 4 o'clock, the next day go to 5 o'clock, the next day go to 6. And then, each 12 hours you move it that 1 hour. So that, within about a week you've got it at bedtime and then in the morning. Make sense? Yeah. I mean, these are kind of common sense things, but you don't really, until you've actually thought about it, you don't get it. 30 days after you have first tapped into that vial, you need to get rid of it. Now, in the hospital situation, they make you do that no matter what. But when you go to educate your patients, a lot of times they'll try to save their injectables and make them go longer than 30 days. This is one of them that you just can't do that with. After 30 days, the effectiveness just kind of starts to wane. So I know you're going, why do I have to weigh the diapers? This is adult. But sometimes if they're comatose and you don't have a Foley in, which is unusual, but it could happen, or say you have an elderly person, weigh the dry diaper or the dry chucks, and then weigh the wet one, and then subtract that dry weight, and you'll have that. 1 gram is 1 mil. How easy is that? Vasopressin is the other drug for this, but the problem with vasopressin is that it can actually raise your blood pressure too high. So it's kind of the second choice on that. DDAVP doesn't typically raise your blood pressure. Vasopressin can.
Have a lot of cardiac issues too, right?
Yeah, I mean, you have to be really careful with it because the vasopressin can also cause water intoxication because the dosing on it is very narrow. So yes, obviously, if you've got water intoxication, what do you have? An electrolyte imbalance, right? So it's an issue. You've got to have your electrolytes within that very narrow range in order to function and stay alive. They do give HCTZ for nephrogenic DI, which is funny because it's a diuretic, but it works. It works. All right. You guys ready for SIADH? All right. So SIADH is exactly the opposite of DI. With DI, you don't have enough ADH. With SIADH, you have too much. So if with DI, they're losing too much fluid, you're having thready pulses, you've got tachycardia, you've got signs and symptoms of shock, what's going to be your opposite with SIADH? Bounding pulses, high blood pressure, fluid overload, right? Jugular vein distension. Did we say high blood pressure yet? Okay, good. All right. So, their sodium's too high with DI. With SIADH, they have too much fluids, so their sodium is too low, right? The biggest cause for SIADH is some sort of trauma to the brain, some sort of swelling. And we said that with DI too, right? So here's the deal. Anytime there's swelling in the brain, you've got to watch them because it could go either way. Some people do DI, some people do SIADH. Make sure you look in your manual of critical care nursing. It has some really good stuff in there. Actually, Baird is really, really helpful for this chapter. All the interventions, all the really bad stuff that goes on, Baird really covers it well. Again, what are we talking about? An electrolyte imbalance, right? So you may not know whether if their sodium is too high or too low, but you're going to start seeing those signs and symptoms of an electrolyte imbalance first with some sort of confusion, some sort of mental decline. They may have the muscle cramps again. They may have the nausea and vomiting. If it goes really far, seizures. All right? The labs, again, are important. And remember, it's not your job to diagnose someone, but it's your job to be smart enough to know when the labs are off and to know when they're off enough that you need to call the doctor. Okay? If their sodium was 136, that's 1 point above normal, you wouldn't freak out over that as much as you would 145. At 150, because it's 135 to 145. So if it were 150, you would freak out over that a lot more than you would at just 1 point over, especially if they're showing any signs. Okay? Their serum osmo is going to drop. This time their urine specific gravity is going to be too high. It's too concentrated. They've got too much going on. Okay? This urine is going to be dark. When you put in your little multi-stick, it's going to show you that specific gravity. You can send it off to the lab for the specific gravity, and they'll put it in a little spectrometer, and they'll charge a lot more money. But in the end, the multi-stick is pretty accurate. All right. So we didn't have enough fluid with DI. We've got too much with SIADH. So they're going to go on fluid restrictions. They don't have enough sodium because they've got too much fluid. So they're going to go on a sodium replacement. Now you're going to give them IV fluids, but they're already overloaded, correct? So what happens is you give them a more concentrated saline solution, a 3% saline solution. It goes in a little slower. You're going to get labs pretty darn frequently, because the minute their sodium comes within normal range, you're going to discontinue that saline. Okay? Because remember, there's a lag. So you get that lab, you send it off to the lab. By the time you get your stat lab 2 hours later, they've had 2 more hours of solution, correct? So think about that and go, oh, well, if their sodium was 135 2 hours ago, they're probably within normal range. So you're going to, make sure you take the steps to discontinue that, get them on a regular IV fluid or discontinue the IV fluids. And again, they're going to go at a much slower rate because you are worried about fluid volume overload. Okay? The initial treatment for this is just a nice, simple Lasix. How nice is that, right? Most of the time it works. The antibiotic below there, interestingly enough, it's just a derivative of tetracycline, but for some reason it increases the water excretion. They usually try the Lasix first and then move on.
That one can actually cause DI, right? That's one of the ones that the drug induced DI?
Yes, actually, yeah. Yeah, that drug can actually cause DI. So you've got SIADH. They can give you a few rounds of it and you're good. So the effects of that are kind of variable. It may work, it may not. But they try each one. Sometimes they'll just have to increase those doses of Lasix until it works. So, and remember, anytime your sodium is out of whack, so is your potassium, right? Because they have an inverse relationship. So you're going to be watching both of those. The biggest thing you can do is figure out what the primary cause is. If it's brain swelling in the brain, got to do what you can do to get that swelling down, right? What's a very quick and easy nursing action that you can do to help decrease swelling in the brain? Head a bed up. Actually, absolutely. If it's caused by a medication, get rid of the drug. So, as a nurse, you are continually going to assess. DI, you're looking for fluid volume deficit. SIADH, you're looking for fluid volume overload. Both of them have your signs and symptoms of electrolyte imbalance. So either way, you're going to be assessing for electrolyte imbalances. Seizure precautions for both of them. And obviously report those lab findings as you get them. And the doctor's going to tell you how often to draw labs. It's not like you're out there on your own. And if they don't, you call them and say, hey, How often do you want these labs? When would you like for me to call you with the report? At what point do you want me to drop these fluids or discontinue these fluids or change to a different fluid? So if they don't give you the answers you need, ask. But before you call them, have a list of all the things that you want to ask. And then have all their vital signs, have their latest labs, have all the signs and symptoms, everything. Have it laid out there so that when he asks you a question, you're not fumbling around going, give me a minute. Okay. All right. Now, growth hormone is kind of my baby. I spend a lot of time working with growth hormone deficiencies. I actually I never saw anyone with acromegaly. Never saw anyone that was in the giantism area. We tested a couple of people for it. We had a 12-year-old boy who was 6'4", and he hadn't even started growing. So we tested him, but he actually just came back. He was just going to be really tall. So, really tall. So with growth hormone deficiency, now remember, all of this is run by the pituitary, right? Pituitary is your master gland. It sends the signal to all of your other glands. So in pediatrics, and you don't have to know this stuff for pediatrics, but it helps you to understand the adult side. So I give you the pediatric information, and you can let it go in or out as you want, but I give it to you because it's helpful. In pediatrics, you will see severe short stature. Below the 3rd percentile, they're not growing, they're just flat as a pancake. Children with growth hormone deficiencies are really, really small. They often have that little kwashiorkor belly on them. They have a decrease in muscle mass and they have a decrease in bone mass. So it's not unusual for these kids to break their bones a lot. One of the biggest problems is that they have problems keeping their blood sugars up. Growth hormone helps you regulate your blood sugars. So kids who have a growth hormone deficiency are little and their blood sugars are low, but they're not hungry. They don't eat very well. They don't care. They're not interested. Again, any midline malformation in the brain, some sort of injury, and brain tumors are a big reason. We catch a lot of brain tumors when kids quit growing. He just isn't growing. I don't understand. And then all of a sudden the kid goes, well, yeah, I have had a bunch of headaches. Well, sometimes this eye's kind of blurry. And you start doing testing and you're like, oh, yeah, it's not such a good thing. Oversecretion is the giantism or the acromegaly, the overgrowth of the bones. The most common cause for that is a brain tumor. But there are a few cases around the world of it's not a brain tumor. They just have it. Their pituitary is just really oversecreting. Okay. Now for adults, growth hormone deficiency may not be as severe as it is for a kid because they don't need to grow so much. However, they do need that muscle mass. Think about it. If growth hormone regulates muscle mass, bone density, bone strength, they're going to be very weak. What is one of the major muscles that you have in your body? Heart. Right. So they may have some weakness in their heart. They're not going to have the strength everyone else has. Their bones are very fragile, so you have to be really careful when you handle them if the deficiency is severe. Most adults make just enough growth hormone to at least keep their blood sugars stable. In really severe cases, they don't. So obviously that's replacement with growth hormone therapy. It's an easy, quick thing to do. If you require growth hormone therapy, it's about $30,000 a year. The upside is that it is completely covered by insurance, Medicaid, Medicare, etc., if you need it. Now, if you just want your kid to be a basketball player, forget it. They won't cover it for that. And they shouldn't. They shouldn't because long-term studies, we aren't sure that actually this exogenous growth hormone doesn't cause cancer. So if you don't need it, you shouldn't have it, right? Why do you think you would need an ophthalmology exam if you had an overgrowth of, or if you had too much growth hormone? Maybe. What? Anybody else? You have to speak up. What you got, Ashley? Nothing.
Well, I thought maybe if the gland was overgrowing, it might cause, it might be blood flow to the ocular nerve, maybe, or blood flow just to the eyes, period.
That's really close. That's really close. It's not actually the gland itself that's overgrowing. It's secreting too much hormone. But the bones are overgrowing, right? So that can put pressure on those ocular nerves. So it can be a problem to lose your eyesight, actually. The growth hormone stimulation test is not bad. It's just a 2.5-hour test. They have to be fasting. You give them arginine and clonidine, believe it or not. And you draw labs every 30 minutes to check and see if they're releasing growth hormone. And if they release more than 10, which you don't need to know that number, they pass the test and they're not growth hormone deficient. They do have to have baseline thyroid function tests, because if your thyroid is low, guess what? You don't grow. Your thyroid has got to be in order for everything else to happen for you in relation to health. It works on your metabolism, it works on your GI system, it works on energy, it works on cognitive functioning. Your thyroid is responsible for so much. So if their thyroid is low, the first thing to do is normalize that thyroid and see what happens. Because if the thyroid normalizes, very often they're able to start making that growth hormone again. With overgrowth, let me explain the labs. The IGF-1 and the IGF-BP3, those are both, that's called insulin-like growth factor. You secrete that from the liver, your body turns it into growth hormone. If you have an overgrowth, you're going to secrete too much of the insulin-like growth factor. So they do actually a 3 or 4 hour OGTT, and they're not checking for your blood sugars, they're checking for growth hormone. Because when they give you the OGTT, your growth hormone levels should be suppressed. If they don't suppress, obviously you're not stopping your growth hormone. The MRI checks for brain tumors, malformations, anything going on in the head. The CT, they only use that if you can't have an MRI. Then the x-rays, they do a bone age if you're below 18 and your epiphyseal plates haven't closed. They actually x-ray your left hand. It's always your left hand. When you're born, you don't have as many bones in your hand as you do when you're grown. So as you grow, they can actually tell your age by looking at your bones, how they develop, the curve of them, the shadows on them, how many bones you have by your thumb, how many little curves you have between this knuckle and that knuckle. They can actually x-ray your left hand and tell how old you are by that. So the bone age, obviously if you're 13 and your bone age reads 6.5, there's a growth discrepancy, right? Right. So now for the overgrowth, they're going to do x-rays of the craniofacial bones because that first overgrowth is going to show in the skull. Okay. Now in the deficiency, we kind of talked about it, low blood sugars, low appetite, headaches, believe it or not, high cholesterol, because your growth hormone helps regulate your cholesterol. They're going to have decreased muscle, fat, and bone. The growth is going to be low in children. You wouldn't see that obviously in adults, but you would see these other manifestations. Overgrowth, again, you've got the joint pain, you've got the headaches. high blood pressure. Now, high blood sugar, because your body's not shutting down that growth hormone. And remember, growth hormone helps regulate your blood sugars, right? I have pictures. These two little boys are the same age. They're actually twins. So you can see there's a little discrepancy in there. One's growing, one's not. That does happen with twins sometimes. It wouldn't matter if they were fraternal twins, but if you are identical twins, obviously it's an issue. So, the lady on the other side has acromegaly, so she has an overgrowth. I think hers was actually a pituitary tumor. I think she's in your book. Is she in the,
There's someone else similar to that.
okay, so I think hers was a pituitary tumor. And you can see it just makes her look kind of large, big boned. So, but if that kept going and kept going and kept going, eventually she would start to look malformed. Treatment's really easy. It's a once-a-day injection. It's a little pen, and it looks like your insulin pens. You just crank up the dose, give them a sub-Q injection, ta-da. Once their epiphyses close, or because insurance companies rule the world, if they reach 5.5, then it's discontinued. Severe deficiency requires a lower dose, but it's lifelong because they can't keep up those blood sugars, can't mediate those blood sugars. With growth hormone overgrowth, it's not like the growth hormone deficiency where you can fix it. You actually can't go backwards. Once those bones are overgrown, they're always going to be overgrown. They just have more bone than they needed. I don't get real tied up in the drugs for this just because you're not going to see them very often. You may see some of the somastatins. Octreotide is a drug that they use for several different things, and it's a somastatin. It inhibits the release of growth hormone, but it also inhibits the release of the thyroid stimulating hormones. So you have to be really careful with it and check their thyroid really regularly. Now, one of the other things that octreotide is used for is for people who secrete too much insulin. It helps block the secretion of that insulin. So you may see a rise in the blood sugars on the people who are on octreotide. And they already have that problem, right? Because they already have the overgrowth, so their blood sugars are already high. And then we're going to give them octreotide, which inhibits the release of the insulin. So bam, now their blood sugars are even higher. So these people are at really high risk for diabetes. So you're going to monitor that. The GH receptor antagonist, that's your Somavert. That's just used when surgery is not an option. Okay. Radiation therapy, if they can't do surgery, they'll try to radiate the area if it's a tumor to try to shrink the tumor. But the most common is the hypophysectomy. Okay. So in the hypophysectomy, they just make a little incision right under your nose, and they go up in through your sinus cavity, and they try to take out as much of the tumor as possible. The upside is that most of these tumors are benign, so they won't necessarily kill you. The downside is that it's hard to get all of it, and they have a high incidence of regrowth. So for the people who had the tumor and now they're growth hormone deficient, you can't give them growth hormone until you know the tumor is completely gone. Because giving them growth hormone will cause the tumor to grow, correct? So, all right. Go figure, huh? The hypophysectomy, you have a lot of teaching you need to do with your patients beforehand. Educate, educate, educate. If you teach them afterwards, they probably don't hear you because it's uncomfortable. And then once they're done, they do a lot of mouth breathing. And so they're thinking about how dry their mouth is, how much they wish they could brush their teeth. You know, they're thirsty. Their breath is probably, could knock a buzzard off. of a carcass. It's not nice. So you're going to teach them before the surgery how important those antibiotic nose drops are. Why is that important? You have broken through their brain barrier, so the chance of meningitis is higher, obviously. So they're at risk for meningitis, right? So you're going to teach them how important those nose drops are. You're going to tell them that they're going to be mouth breathing. Sometimes if things are really swelling afterwards, if they're still kind of out of it, they'll even put in an ET tube to help them breathe. Mouth care, they cannot brush their teeth. For like 2 weeks, you can't brush your teeth. So lots of mouthwashes, lots of rinses, keep some swabs around, let them kind of, those little pink squishy things, you can use those very gently. But no vigorous toothbrushing at all. No toothbrushing at all. Because you've got that incision and you don't want to disrupt that incision. You just don't want to do anything that would cause bacteria to get up in there and cause meningitis. So they're going to be in a lot of pain. They're going to be very uncomfortable. Now, you've just gone in and you've removed a tumor on the pituitary. Now remember, the pituitary controls your thyroid. It controls your adrenal glands. It controls your sex hormones. It controls your growth hormone. It controls everything. You've just messed with the little ball of fire that controls everything. Your patient may need hormone replacement for everything for the rest of their life. If all goes well, they don't. We're practicing medicine. It doesn't always go well, right? And once they get in, sometimes the tumor's bigger than they thought, or they're not able to get it all, or just the wiggling around of that pituitary gland can cause some transient issues. So you're going to watch for those. You're going to teach your patient to avoid vigorous coughing, so that whole turn cough and deep breathe thing is out of there, right? They can, ish. They can deep breathe to some extent, but what does deep breathing do? It causes you to cough. So getting them up and getting them to walk is probably the best thing you can do. Having them stay in the bed is detrimental. Give them some Colace. We don't want them getting constipated because straining to go poopy can put pressure on that, cause it to open, cause a leak, right? So they're going to have a little dressing under their nose. It looks like a little mustache. They actually, when they go in, they take a little bit of skin from your thigh to patch the little graft site. So they're going to have 2 different areas. They're going to have something here, and they're going to have a dressing on their thigh. So you're going to take care of that site. Tell the patient to report any increased swallowing or postnasal drip. A lot of patients will say it tastes kind of metallic. You're looking for a leakage of their CSF. Because a leakage of CSF means that the wound isn't closed all the way, higher risk for meningitis, higher risk for any kind of other infection, etc. If they've got really bad headaches and they're not going away, they need to report that. I mean, they're going to have a little bit of a headache at first, but if it's really severe and it doesn't go away with medication, they need to let you know. Why would you need to bend at your knees and not at your waist? Yeah. Bending at the waist gives more pressure here. But if you bend at the knees, obviously there's not as much pressure up here. So, head of the bed elevated at or above 30 degrees at all times. Sir, why? Decreasing the pressure. Exactly. That's a simple thing. That's something everybody can do. Don't need a doctor's order for it, right? Exactly. Monitor their neurostatus. So if you see any changes in the neurostatus, you're going to monitor that. To check for a CSF leak, if you start seeing a little halo-looking drainage on their mustache dressing, that's kind of a combination of your CSF and a little bit of blood. If you see that, just go get one of your multi-sticks, press it up against the leakage. If it comes up glucose positive, you need to call the doctor. If you can catch some of the drainage, you can send it to the lab, but typically it's just kind of a little slow leak. So you would just get out your multi-stick, press the glucose tab up against the drainage and see if there's glucose in it. Normal snot does not have glucose. I don't care how good kids say it is, it doesn't have sugar in it. Okay? Obviously, monitor for DI and SIADH, right? Because you just messed with their brain. I don't know why I didn't put SIADH on there. All right. We're going fast. Prolactinomas are one of the bigger or one of the more common tumors on the pituitary. Usually the first sign of it is that someone is giving off breast milk who should not be. This includes men. A man will wake up one morning and he is secreting breast milk, and let me tell you, he flips out. Not saying, I'm just saying. I had a friend once who never had children, wasn't pregnant, nothing, and she goes, something is wrong. And I said, what? She goes, I'm lactating. I was like, yeah, that's kind of an issue. So yeah, she had a pituitary tumor and she had to have the surgery, but she was one of the lucky ones who didn't have any long-term residual effects. But with both sexes, they're going to have the lactation, headaches, and vision changes, and then causes changes in your sexual functioning for both men and women. What's the treatment? Hypophysectomy. What do you do with a hypophysectomy? We just talked about it. Teach, head of the bed up, monitor for meningitis, intracranial pressure, the CSF leaking, head of the bed up, right? What are you going to do as a nurse? Whenever I tell you something, go, what would I do? She just gave me this information, but what would I do with it? So, they can, if it's something that they can't treat, or if they need to shrink it, they can actually give Parladel, which is an agonist. It's a dopamine agonist. Now, agonists are drugs that act like a naturally occurring substance. So it acts like dopamine, right? Well, dopamine, in addition to doing all the other wonderful things it does, also inhibits prolactin secretion. And remember, prolactin is the hormone that makes you lactate. So it may shrink the tumor, may not. It's an older drug, it's tried and true, but it has a lot of side effects, especially initially. So initially, they may have nausea, they may have sweating, they may have pretty bad orthostatic hypotension, they may have nausea and vomiting, diarrhea, heartburn, loss of appetite, they may get sleepy. Now, if they start you off at a low dose and then gradually increase it, these signs and symptoms are a lot less severe. But if they just start you off wham bam on a higher dose because they need to get that tumor shrunk quickly, you'll have a lot more of these. If you have all those signs and symptoms, you just call the doctor, and the doctor will probably decrease that dose until your body can tolerate it a little bit more. The big warning sign with Parladel is don't give it to a person who's just had a baby, a woman who's just had a baby. To prevent lactation, it can actually cause death. So that would be, in technical terms, that would be bad.
Would you not give any kind of dopamine agonist then?
I don't know. You just don't give Parladel. I don't have that answer. So, good question. It's also contraindicated with Raynaud's syndrome. So apparently there's some cardiac issues that go in with Parladel. The cabergoline is also a dopamine agonist. They don't give it as often because it's more expensive. It has fewer side effects. You don't have to titrate up quite as much. But because it's more expensive, they don't give it as often. Kind of a bummer.
They maybe switch you to that if you're experiencing all those.
Yes. If you can't tolerate the Parladel, they can switch you to the Cabergoline. Right. And they do have to, titrate it up a little bit, but they don't have to go as slowly, and the side effects are not as severe. So, again, your nursing considerations: educate, 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 and then take care of them postoperatively, because it's a hypophysectomy, right? How easy is that? All right, let's take a 10-minute break. All right, I'm ready. Are you ready? Yes, we're ready. This is everybody speaking. Did you guys forget to say hi to OPSU this morning? Everybody say hi. Hi. Hi.
You want to make the second option?
Oh, I probably did. Sorry. They get what?
They can stay home and just listen.
Yeah, that's true. They get the couch side view. It's kind of nice. So I think some of them do go to class though. All right, so let's talk about the adrenal gland. Let's talk about the adrenal gland. All right. So the adrenal glands are just two little tiny peanut-shaped glands that sit just right on top of the kidneys. Now, what drives the adrenal gland? The pituitary. So if your pituitary is not working, your adrenals don't work. Oh, and Sean Cree asked me such a good question. Thank you for asking that. Just to solidify this concept in your mind, when you're having a hypophysectomy, they're not taking out the entire pituitary. They're only taking off the tumor. So that's why you may or may not lose all function in your pituitary. Okay? I'm sorry, I didn't mean to muddle that up for you guys. I'm so glad you asked that question. Okay, so the adrenal glands are responsible for quite a bit, actually. They produce all your steroids. They help with your fluid balances and your water balances, and they help your body to work with your sodium and water and excretion of potassium. So they regulate your minerals. They do all this good stuff, right? So let's start off with your glucocorticoids. That is your steroids, your cortisol. All right? Your steroids, your cortisol, your body puts out just a little bit every day to help you get through life. Because cortisol is essentially your stress hormone. I know you've seen those ads on TV that talk about how stress is what's making you fat. It's not. But, it's a nice thought. I wish I could say that that's what's made me fat. It's the pizza I had for breakfast. But anyway. All right. So anyway. You put out a little bit of cortisol every day to help your body with stress. And you're like, but I'm not that stressed. Getting out of bed is stressful. Getting out of bed is stressful. Jackie's over here like, yes, it is. But physically, I'm talking about physical stresses. I'm not talking about mental and emotional stresses. I'm talking about physical stresses on your body. Yes, constant mental stress can mess with your cortisol, but mostly what we're addressing with stress in relation to this is physical stress, okay? So your body puts out just a little bit every day of the cortisol because in addition to your growth hormone regulating your blood sugar levels, cortisol is the big giant factor in keeping your blood sugar high enough to keep you alive. If you are severely deficient in cortisol, you can't keep a blood sugar up. You're going to crash, you're going to bottom out, you're going to go into seizures and croak. It's bad. So if you're deficient in cortisol, obviously that's an issue, right? Now, the other thing that cortisol helps you do is it helps with tissue repair, and it helps you to fight infection. So that's why when you get sick, a lot of times the doctors will give you one of those little dose packs of the steroids. It's to help your body. It gives you just that little bitty boost to help you get over the inflammation. Helps with all your metabolic function. It helps with cardiovascular. Now, your mineral corticoids, I know you guys in MedSurg 1 talked about your aldosterone, renin, angiotensin system. I have to tell you that whole thing right here. For me, what I need to know about aldosterone is that it regulates my sodium and potassium and water balance. Okay, so it's my mineral corticoids. Okay, that helps me keep my blood pressure up. So if I'm deficient in mineral corticoids, my blood pressure is going to be too low. Helps me to keep my sodium and potassium straight. So if I'm too low in my mineral corticoids, if I'm too low in my aldosterone, and my blood pressure is too low, what signs and symptoms am I going to exhibit? Hypovolemia, signs and symptoms of shock. Can you see how almost all of this leads back to signs and symptoms of shock? Either fluid overload or fluid volume depletion. A lot of endocrine is all about that fluid volume. So one of the things you're going to monitor for, where are they on their heart rate? Where are they on their pulses? Can you feel those peripheral pulses? Are they bounding? Are they threading? If you don't have enough of the aldosterone, you're going to urinate too much. Again, fluid imbalance, right? Okay, your androgens we don't talk about a whole lot in here. I'm sure you covered that in some other part of this course. But basically your androgens are responsible for your male sex characteristics. Males and females have androgens. Women need testosterone too, they just don't need as much. Okay? Epinephrine, that's your adrenaline, and your norepinephrine. Both of those are your fight or flight type thing. They increase your blood pressure, they increase your heart rate, they increase your stroke volume, they dilate your pupils. They're what helps you get over a crisis. So that's what helps you when the train is coming straight at you to jump off the tracks instead of stand there like a deer in the headlights. Somebody really needs to do a test on deer to see if they have epinephrine and how much epinephrine they release right before a car hits them. I guess that would be unethical, right? Jeez, ethics. It's always in the way. Darn ethics. Norepinephrine also helps you get more energy from your fat stores. So, yay fat stores for Miss Sharon. Yay. Here's hoping I don't need it, but anyway. So adrenal insufficiency is a big problem. The patient who is adrenally insufficient can go into an adrenal crisis and die on you just that quick. So, what causes adrenal insufficiency? Again, you've got your birth defects, those midline birth deformities that caused your pituitary not to work. There's also some birth defects. There's one called adrenal hyperplasia, where your adrenal glands don't function the way they're supposed to. That's one of the tests that they pick up on when they do the newborn screening. So they used to think that, there's one called congenital adrenal hyperplasia, it's CAH. They used to think that little boys didn't get it. But boys would mysteriously die around 11 days of age. Girls, however, because remember, your adrenal glands are also responsible for your male sex characteristics. So little girls would be born, because they were making too much testosterone in utero, little girls would be born with ambiguous genitalia. So it was really easy to figure out when little girls had it. However, little boys would be born perfectly fine because they were just putting out excess testosterone, so, you couldn't tell. But little boys were mysteriously dying around 11 days of life because their adrenals weren't functioning, their aldosterone was off, so they got dehydrated, their fluids and electrolytes were off, cardiac failure, right? But now with the newborn screening, it's completely preventable. At the OU Children's Endocrinology Center, all the newborn screening that's abnormal in the endocrine section gets called into them, and they call the families and say, hey, your newborn screening came in abnormally, and we need you to get in here as soon as possible and quicker than that. Luckily, that screening gets done really quickly, usually within about 4 or 5 days. And so it really has cut down. They call it SIDS. There's really no such thing as SIDS. There's just a bunch of undiagnosed stuff. So it has really saved several lives since they instituted that. Now, you can also have autoimmune responses that cause your adrenal glands to shut down. Obviously, if you have your adrenals removed, that's adrenal insufficiency, right? Sepsis causes your adrenals to shut down. So whenever someone's in sepsis and they're giving them high doses of steroids, there you go, right? Of course, if they're in sepsis, they've got a really bad infection. And what does your adrenal glands do? They help you fight infection, right? And remember I told you that if someone gets really sick or if they have a real long-term illness, that it can kind of make your pituitary not work as well and can make those functions shut down a little bit. So think about that. Secondary causes, when people are on steroids and they discontinue them just suddenly, what happens is when you're getting external steroids, your body doesn't produce as much because you've got what you need. Remember, it's the negative feedback system. So your adrenal glands say, I don't need to produce as much, so they don't, which is why you have to taper your steroids. If you don't taper, you pull that cortisol from the body all of a sudden, and you haven't made any, and bam, you're in an adrenal crisis. So it's really important to educate your patients on why not to discontinue it, because your adrenal glands have to have a chance to start functioning again. All right. Remember, the pituitary mediates everything, so if the pituitary is not working, neither are your adrenals. If they had that hypophysectomy, it may be permanent, it may be temporary, but they're going to need help getting their adrenal glands back on track. Okay. Let me look at my notes, make sure I haven't forgotten to tell you anything. All right. So far, so good. Have I told you guys how brilliant I think I am? It's true. You should all just agree. Except I have a bad memory, so don't let me forget to talk about cash cab when we're done. Okay? All right, so clinical manifestations. Fatigue's going to be probably the first one. Low blood sugars, obviously, right? They're going to be craving salt because they can't retain their sodium, correct? So they'll eat bags and bags and bags of potato chips. And their skin, for chronic acute adrenal insufficiency, their skin will be real darkly pigmented. So someone like me might look like someone from Saudi Arabia or India or whatever, and then we'll have darker patches. They call them cafe au lait spots. And we would have little darker patches on us. And it obviously, if I'm standing next to my sister, who's, pale white girl, she and I look like twins. But if I had adrenal insufficiency, I would not look like her twin anymore. It would be very obvious. But it might not be obvious if you didn't know us. You just might think, oh, she inherited her mom's Cherokee blood, whereas she didn't. And in reality, neither one of us look Cherokee. Doesn't make it lick a sense. It is not hard to tell for them because, again, they have the little cafe au lait spots. It's real normal for them to have one big cafe au lait spot right above the tailbone. So just right above your rear end will be a little darker spot. So that's not unusual. Well, and the Mongolian spot is something they look at. If you have a really, really dark one, a really, really big one, they'll look at you for adrenal insufficiency when you're born. So, but then when they get the labs back, if they were normal, they're good. Let's see. Postural hypotension. Why would you have that? fluid volume, right. Hypoglycemia. I don't know why I don't have that on here, but hypoglycemia is going to be a big one. And then your sodium and potassium are going to be off. You actually, because your sodium and potassium is off, you're going to have high potassium, you're going to be in metabolic acidosis. So if they did a ABG on you, that's what that would reveal. It helps them diagnose it. So for people who don't make enough cortisol or make enough of the hormones from the adrenal glands, adrenal insufficiency on a day-to-day basis to keep them from going into a crisis requires replacement, right? These are not optional. This is not something you can take for a while and then go, I don't like taking pills, I think I'll stop. People who do this get really, really sick really, really quickly, all right? You've got to take Cortef, and that's just external cortisol. It replaces your cortisol. One of the biggest things you hear is people saying, I don't want to take steroids. Steroids make your bones fragile. Steroids do this. Steroids do that. That is so true. If we were giving you more than what your body needed. But remember, your body makes a certain amount. You need a certain amount to survive. We give you a replacement for what your body's not making. So make sure you educate your people on that too. You know, it's a replacement for what your body's not making. It's going to be given 2 or 3 times a day at regular intervals because your body would normally secrete just a little bit of cortisol all day. Remember, you secrete a little bit more at night, and then during the day it's a little bit less. But you have to have kind of a steady supply of cortisol. Florinef is a real easy little pill. It just replaces your mineral corticoids, and so that helps you with your minerals. So when a family doesn't get their meds refilled and all of a sudden they're having a hard time keeping up with their sodium and their fluid volume, you know, that's it. They just need to go get that medicine refilled. This is one of the things that these 3, even when your patient hasn't come to see you in a year, you call it in. Now, you might only call them in a week's worth so that they'll get in your office and come see you so that you know they're doing okay. But you do not withhold these medicines because they haven't been to see you. That would be dangerous. That would be unethical. Okay? Now, typically when you get sick, let me see if I have this on the next one. No. Okay. Typically, if you get sick, as long as you're able to hold down your medicines, they will just have you triple your dose until you're not sick anymore. Because remember, when you're sick, your body secretes more of these hormones, right? So when you get sick, we ask you to take more, usually triple it, for a couple of days until you're better. If they are unable to take their meds and they've got irretractable vomiting or any sort of physical crisis, like say they were in a car wreck and they broke a leg, that is a physical crisis when your body would normally send out a huge surge of these steroids. That's when you have to give them Solu-Cortef. Now, Solu-Cortef, I'll talk about it in a second. Solu-Cortef is just an injectable, and it is what is given in an emergency. Now, how many people are on an ambulance up here? Crystal is. Who else? What's your name? Chastity. Okay. This is one of those things that they're trying to get the ambulances to stock, but most ambulances don't. Because if someone in a severe adrenal crisis needs that Solu-Cortef right then and right there as quickly as possible. So if they cannot tolerate their oral meds or if there's some sort of crisis, you want to give them an injection of the Solu-Cortef. So when is this critical? If they can't stop vomiting, if they got a fever above 101, even if you know it's viral and they're going to get better in a couple of days, they need to triple their dosing. Any sort of infection requires triple dosing. Hospitalization, obviously. Any type of surgery, even oral surgery, they're going to have to triple that dosing. If you come in and they're lethargic, That's obviously a big deal, right? Okay. First signs you're going to see is the signs and symptoms of shock. They're going to have low blood sugar. If you've got time to get labs done before you start taking action, and you're going to get the labs while you're starting the IV. You're going to be starting fluids, getting them ready to go, getting them rehydrated. But when you do get your labs back, you're going to find out that their potassium was high, their calcium was high, their sodium was low, their volume was low. Okay. The ACTH stim test is really a very easy test. It's a 1-hour test. You start an IV on them. You draw labs to check for cortisol. You give them some medicine, slow IV push, and I mean slow IV push. Take labs every 30 minutes for an hour. They check to see if their cortisol level rose. If it rises above a certain percent, they know that their adrenal glands are working enough to take care of their needs. If not, they know they need to go on these meds. It's a really simple test. It's not expensive. It's easy to do. And if you can't get an IV, you can do finger sticks. So it's not bad. When there's a medical emergency, when they can't hold down their pills, when they've been in a car wreck or they've had surgery or whatever, Solu-Cortef is what you want them to have. The picture on the left is the one that they should get from the pharmacy. So if you're taking care of this patient and they get the one on the right, you need to send it back. Now in the hospital, it wouldn't be any big deal to have the one on, yeah, sure, right too, right? It wouldn't be any big deal to have the one on the right because you have everything you need to reconstitute that and give it to them, correct? But one of the big things that you have to do with these families is do education on how to take care of this at home, because you can have an adrenal crisis at home. So they need to be able to give an IM injection, so you have to teach how to give injections. You have to teach them how to reconstitute. You have to teach them how much to give, because in an adult you're going to give the whole thing, but in a kid you wouldn't give the whole thing. Now, if the pharmacy gives them the one on the left, all they have to do is push the button down. They have the saline in there. It reconstitutes the medicine. All they have to do is pull it up and give it, right? Now, hopefully the pharmacist has given them needles also. That's part of the prescription process. What we find more often than not is even when we order the one on the left, it's called an active vial, the pharmacists give them the one on the right. They don't open that package. They don't look at it. They don't think about it. But then when there's an adrenal crisis, they open that package, they pop it open. Oh, good, powder. What do I do now? They don't have anything to reconstitute it with, and it's very likely that the pharmacist didn't give them any needles either. So how are we going to get this in our body? We're not. We're going to call 911. Hopefully the ambulance will come and they'll have stuff to reconstitute it with. So this is an emergency. This is urgent. You can't go, I think I'll wait a few hours and then take care of it. It's too late. You've got to take care of acute adrenal crisis right then and right there. Other than your Solu-Cortef, you're going to do fluids because they're volume depleted, right? So we've got to get those fluids back up. It's going to have normal saline in it because they're depleted in their saline. They're going to get that initial dose of Solu-Cortef, and then you're going to run it in an IV, just a steady drip of it constantly. And then they're going to get more of the injection every 8 hours until they're better. Yes, ma'am.
Even if they can take PO?
If they're sick enough that they need this, you're not going to go back to PO for a while. It's going to be a few days. So you're going to manage their hypoglycemia. You're going to manage the electrolyte imbalances. As a nurse, what are you watching for someone who has an electrolyte imbalance? I hear some people over here, what? I can wait. I'm going to make everybody flip because all the shy people are in the back and all the people who aren't as shy are in the front. So, yeah. Because their fluid volume depletion, their electrolytes are off. So it all goes back to level of consciousness, potential for seizures, potential for cardiac implications. Get that fluid balance up, get those electrolytes back into order. Make sure your patient's safe, right? You're going to be on their vital signs like a duck on a June bug. You're going to be taking those vital signs constantly because you want to know, are they getting worse or are they getting better? And if you only take their vital signs every 4 hours, you've waited too long. So vital signs every 30 minutes, maybe even more often in the beginning. You're going to continue to assess them for all the stuff that goes with that crisis. Be looking at that fever to see if it's coming down. Be looking at their hydration status. You know, if they're really dehydrated, you're going to run a little bit of a fever anyway, right? But if they're dehydrated and they're in the crisis because they're sick, then we need to manage the illness that's going on also. They're probably going to need some antibiotics if it's some sort of bacterial illness. If it's viral, you have to wait it out, right? Yeah. And obviously if it's some sort of trauma, you got to take care of the trauma, and then you still have to wait it out, give them support until their body can stabilize. Cushing's. Cushing's just isn't as exciting, but you know, it's important. So, yes, ma'am.
On the slide previously said abdominal pain. What's making their stomach hurt?
Their electrolytes are imbalanced, so there's abdominal pain that goes in with that. They're dehydrated. They probably feel sick to their stomach. So it's called part of that being dehydrated and feeling crappy, and it's just all a part of it. All right, Cushing's disease. Over here we've got adrenal insufficiency. Over here we've got Cushing's, which is too much, right? All right. Basically, Cushing's is just an excess of your cortisol. Now, got a couple of different reasons for it. You've got the syndrome, which is when they're on too many steroids. If they're on too many steroids, it's been a long-term thing. They're on these steroids for a reason, right? So you can't just stop them. Say someone has lupus. Say someone has JRA. Some other sort of inflammatory disorder. They kind of have to keep their steroids going. And then we do give it to them in doses bigger than their body would normally make because they have an inflammatory disease, right? So, the other reason for it is just too much internal production of cortisol. The thing about Cushing's is that it affects every body system that you have, okay? The most common cause of Cushing's disease is a pituitary tumor. Again, because the pituitary mediates everything. So if you've got a pituitary tumor, it's overfunctioning. Now remember, it can over or underfunction. So you just don't know which way it's going to go. It's like a mystery. So if it affects all your body systems, that means that your total body fat is going to go up because you've got too much, right? They're going to have the buffalo hump on the back of their neck. Going to have the moon face. Their body will be really big, but their arms and legs look like little sticks. So I tried to find. I have a cartoon character in mind for this because you've seen clowns or cartoon characters who have the really skinny legs and then the really plump bodies.
Mr. Crab on SpongeBob.
Mr. Crab. Okay. I mean, I even Googled cartoon characters with truncal obesity and cartoon, yeah. Because I was going, I know that there's a caricature out there somewhere. But yeah, really skinny legs and arms, bigger trunk. All right. Now, obviously, obesity is an issue, but it's not their main problem. It is an issue, but remember, being obese puts stress on your heart, it puts stress on your organs, it puts stress on your arteries and veins. But also, the person who's got too much cortisol, Too much cortisol causes tissue breakdown, right? It causes breakdown of tissue proteins and your urine nitrogens. So their skin is going to get thin. It's going to peel real easily. I had a patient once that, bless his heart, I was just trying to sit him up in the bed, and when I touched his arm, his skin came off like a little sheet, kind of like phyllo dough. And by the time he left the hospital, he looked worse than he did when he came in. Now internally, and he actually ended up going home on hospice, because every time we touched him, we tore his skin. And it was horrible, because even when we were just trying to turn him every 2 hours or change his position, he could get up to the bedside commode. Getting him up tore his skin. He had little tears everywhere. I felt really bad for him. So obviously their skin gets really thin, their bones become really fragile, your muscles become weak, your capillaries have a tendency to break, they become really, really fragile. Because they're weak and because their bones can't support them as well, there's a really high incidence of falls. Also a really high incidence of bone breakage there. And sometimes the bone breaks and then they fall. That actually happens a lot with hip breaks. They think, oh, he fell and his hip broke. But actually, I had a friend with lupus who had massive doses of steroids who her hip broke and then she fell. So, because I was there and I heard it. And there was a tornado coming. It was not good. So, I should tell you that story. We have time. So she had really bad lupus. This is not on the subject, but her hip broke. She fell. We were trying to get into my house because there was a tornado coming, and my basement was 20 feet away. And she couldn't get up. She was kind of one of those people that she cried wolf a lot, so you weren't really sure when she was really sick and really hurt. And she's laying there on my deck, and I can see the stuff swirling overhead, and I said, "Get up." And she said, "I can't." And I said, "You get up right now." And she said, "I can't." And I said, "I will drag you into that basement, or I will leave you here." Because I was new to Oklahoma. I was not used to all that. It scared me. So I actually did try to drag her into the house, and I couldn't do it because she was extremely obese because of all the steroids. She probably was about 450, 500 pounds. So, yeah, I tried really hard to drag her into the house, and I was not successful, and I was obviously very distraught. But she ended up having to have her hip pinned and then replaced, and what did I do? I called 911. I stood there going, "Please, funnel cloud, don't drop." So, and I actually was a little mad at her. So not therapeutic for you guys to hear, but before we had gone off to do our stuff, I said, there's weather coming in, and I'm a little nervous about it. And she said, "You people who aren't from Oklahoma are such chickens." And I let her goad me into going out. And I told her before we left, I said, "Fine, I'm going, but if anything happens, I will never forgive you." Which is why when her hip broke, I was like, "You get up right now." It was not therapeutic at all. Yeah. But I'm telling you what, I put out some cortisol. Guarantee you I put out some cortisol. Okay, anyway, sorry. Back on subject. You guys didn't need to hear that story. Anyway, so increase in acne, increase in hair, so they'll have a lot of hirsutism, a lot of facial hair. Increase in their androgens, so overproduction of the sex hormones. And they'll have male pattern baldness. So let's just add insult to injury and talk about hurting your self-esteem. They're really chubby, they have stick legs, they're going bald, they're hairy, they've got acne. I mean, come on. This is just, it's got to be very frustrating to be that person. And talking about disturbed body image, right? So, as a nurse, to communicate therapeutically with this person would be really important. So, GI, it actually causes increased acid production. So the patient with Cushing's would need to be on some sort of thing to reduce acid production, ranitidine, Zantac, something like that. They usually give it IV, especially if they're really seriously into some sort of Cushing crisis, because just the tablets are not helpful. And remember, their GI system's upset, so oral meds may just run right through their system without getting to be effective. Okay. They've got altered electrolytes, altered sodium and fluid balance, so they may have some cardiac changes, right? They may have hypervolemia. Their blood pressure is going to be high. Their pulses are going to be full and bounding. You know, it's your classic signs of hypervolemia. So, and then they just do cortisol testing on them to see what's going on. Urine test, they do a 24-hour urine test to see if they're putting out too much cortisol. The salivary cortisol test is actually just a little thing where you scrape the inside of their mouth around midnight with a sponge. You know, it's obviously one of the special sponges, but it's not spit. If you just, that's not going to test the cortisol levels, but it's actually the saliva that collects in your mouth is what you want to get. If you get their labs back, you're going to see classic signs of fluid imbalances, right? Their ACTH, which is the adrenal corticotropin hormone, is going to be increased. And why would they have decreased lymphocytes? Messes with their immune function, right? So excess steroids, while they help us with our immune stuff, too much of it makes us have immune problems. So, our bodies are so narrow, aren't they? You don't even think about it. Every day, our bodies maintain that homeostasis in such a narrow range, and too much of something sends you into a tailspin, and not enough of something sends you into a tailspin. And we work all day at keeping ourselves normal. We have no idea what a miracle we are. None. So, all right. You've got your different drugs that decrease your cortisol production. Cyproheptadine is one of the main ones. It just interferes with the production of that ACTH. Lisidrin is actually cytotoxic. So it's one of the chemotherapy type drugs that they use when you have a tumor that's inoperable. Okay. Surgery, if it's coming from the pituitary, hypophysectomy, right? If it's coming from the adrenal glands, now remember I said the hypophysectomy, they don't take out the whole pituitary, they just take out the tumor, right? Well, with the adrenal, they have to take the whole adrenal gland. So, now sometimes they can just take one, but if they have to take both, what just happened? Now you're adrenally insufficient. Yeah. So you went from one extreme to the other, right? So when you're looking at how to take care of this patient, when you're looking at your nursing actions, look at your fluid volume issues, look at their skin. A temperature elevation of even 1 degree Fahrenheit is significant. So you don't wait for those to go up, you get on that right away, because that could mean an impending infection, which means they need a little bit more or a little bit less. So serum electrolytes, obviously those are off balance. Because you've just done an adrenalectomy, they're at risk for an adrenal crisis, which goes back to the other slides, right? All right. A pheochromocytoma is basically a tumor on the adrenal medulla. Usually they're benign, so they're just like the pituitary tumors in that usually they're benign, but it's causing an issue, so it's got to go. The upside is that if it's not metastatic, it won't necessarily spread and kill you, but it still has to be taken care of. It's not something you can just leave there. They store the epi and the norepi, so when they release it, you end up with severe hypertension. So they'll come up and they'll go, man, I've got a terrible headache. And their face will be all red and they're just really nervous and jittery. And it's kind of like an anxiety attack. Feel a lot of sense of impending doom. Just in case, and I know someone has said this before, if your patient says, I think I'm going to die, listen to that. Because they know. They know. And a lot of times they're right. A lot of times they're right. So if a patient says, something's going on, I think I'm about to die, try to take action. So, again, that blood pressure is going to be really, really high, and you're going to have to do what you can to get it down. They just diagnosed this with another 24-hour urine collection and an MRI. Now, the 24-hour urine collection is going to do what? It's just going to tell them you're making too much cortisol. The MRI is what's going to be, that tells them you have a tumor.
The hypertension and all that stuff, that can be intermittent, right? They can have really low blood pressure.
Yes, it can be intermittent. So, the low blood pressure doesn't necessarily make it low. So, but yeah, I mean, this is an intermittent thing because remember I said it stores it up. So it stores your epi and your norepi, and then bam, it releases a bunch of it. So, and that's why sometimes it gets misdiagnosed as an anxiety attack, because once it's released it, in a little while your body goes back to normal. So sometimes they go, it's just an anxiety attack. So, what you're going to do as a nurse before that adrenalectomy is support whatever's going wrong. So if their blood pressure's high, they're probably going to order some propanolol or something else to get that blood pressure down. If they've got a fever, you're going to be giving stuff to get that fever down. You're going to be putting them on a cooling blanket, minimize their stimulation, turn the lights out, make it calm, make it peaceful, etc. Do not palpate the abdomen pre-op. I was like, do I really need to tell them that? As nurses, do we typically go around pushing on people's bellies unless they've just had a baby? Not really. If their belly's really, really tight because they've got the fluid on the belly, you're going to tap on it, you're going to feel it, you're going to test it for firmness or tenderness or this or that. But this is deep palpation. If you palpated them deeply, it could stimulate even more of an adrenal crisis. So don't palpate their abdomen deeply. I wasn't sure if I really needed to say that, but I thought as sure as I don't, one day someone will go in and go, he's got an adrenal tumor. I'm going to see if I can feel it. Bad. Okay. Here's the part where I think we fail our patients. People with any sort of adrenal issue should wear a medic alert bracelet just like diabetics should. And it should say, adrenally insufficient, give Solu-Cortef. And 100 milligrams or how much ever they usually get. Because that could save their life. Again, not something they always have on the ambulances. So the ambulance is just going to have to get the fluids going on them, get them started on stuff as soon as possible. Get them to the hospital so that they can get that Solu-Cortef in them. Oh my gosh, I can't believe how fast we've gone. Have I gone too fast today? Okay. You guys, I totally forgot to tell you this too. I actually ended up making some changes to my PowerPoint, which I know you guys hate. But I will put up the new one, and I was going to yesterday, and I came to school to do it after clinicals, and all kinds of horrible things happened, and I didn't get it done. So I'm sorry that you guys printed out the one you have. It's got a few minor changes in it. There were a few slides that I completely deleted because they all led to the same thing. They all led to adrenalectomy or hypophysectomy or this or that and the other thing. And remember, it's all about those nursing actions. They weren't things that were necessarily in your objectives. So I was like, do they need to know all this? No. You need to know what to do. So now, this case study is actually it's not an abstract person. This is someone that I took care of. He was a neat young man. He came into our clinic. He was 33 years old, and he looked like he was 11. He had not grown since he was 11 years old. He was from Africa, so he had never had any, and he had lived in a rural area. He had never had any testing. He had never had any sort of medical workup for it. He just knew he hadn't grown since he was 11. His body hadn't changed. He hadn't gone into puberty. Nothing had happened for him since he was 11. Now, he worked like a grown man. He did roofing. He did all kinds of physical manual labor, and he was very muscular, very well built, but he was really upset because here he is, 33 years old. He hasn't progressed into puberty. He hasn't grown. He hasn't done any of the stuff. And so he was actually kind of in a stasis. He couldn't get married. He couldn't, really support a family. He had all these things that he wanted. So his bone age read 11, and it was a small 11 too. All of his labs were abnormal. His free T4 and TSH were in the tank. Just almost didn't even show up. His IGF-1 and his IGF-BP3 were really, really low. And remember, that's that insulin-like growth factor. You have to have that in order to grow. And his cortisol levels were really low. We did an MRI on him, and it revealed that he'd had a shrunken pituitary. Something happened when he was 11 that basically decimated his pituitary gland. I don't know. He didn't remember being sick. And then we did stimulation testing on him, and his stem test came back completely flat. He did not stem at all. So whatever happened to him when he was 11 just decimated his pituitary gland. What we really don't know is how he survived. Because somewhere between 11 and 33, surely he had to get a virus of some sort. Surely he had to have cut his finger or hurt himself or something. But somehow he survived. And he was just so personable and just so fun and so full of life. And unfortunately, because he was from Africa, he didn't have insurance here, and we thought, are we going to be able to help him? Well, we knew we could replace his thyroid hormones, right? So that was awesome. We were able to replace his thyroid hormones. And, thyroid, if your thyroid's not functioning, you don't grow, you don't have good metabolism, etc. Cortisol, both thyroid hormones and cortisol, $4 prescription a month from Walmart, even if you don't have insurance. So, remember I said that growth hormone's about $30,000 a year? We were able to get the growth hormone companies to donate that for us. So, we started him on the levothyroxine, and then after his thyroid was stabilized, then we started him on Cortef. Now, if you do it backwards, if you start him on Cortef before you stabilize that thyroid function, you can actually cause an adrenal crisis. So we started him on the levothyroxine first, then started him on the Cortef. And once that was all stabilized, we started him on growth hormone. Last time I talked to my people, he had grown quite a bit more than this. He's grown probably about 4 inches in the last year and a half, 2 years. Normal growth is about 2.5 inches a year. So we are actually changing his life, changing his future, because once he gets a little taller, he's stronger, he's ready to go, then we're going to replace his testosterone and his other puberty hormones, and he'll be able to go on into puberty and just be a normal person, just like you and me. He will need maintenance growth hormone for life because he is an adult with a growth hormone deficiency, so he needs that growth hormone to help his muscles develop. Remember, you replace your cells about every 90 days, right? So if you're replacing those cells and you don't have something to build up the new ones, then you're not going to be as strong, you're not going to be as weak. Heart problems down the line, other big organ problems down the line. So he will need maintenance for the rest of his life, but we have really changed his future because now he'll be able to get married. I mean, no girl was going to take him seriously. He looked like he was 10. You know, what grown-up's going to take him seriously? Plus, as far as sexual function goes, he just wasn't going to have any. You know, not enough to produce children. So now his whole outlook has changed. And it's just such an amazing story. And I wish I could still go see him and talk to him, but I get reports every so often on how he's doing. So, all right. We don't know what happened. I don't know why he didn't get sick, other than, I don't know. Okay, don't shuffle papers yet, because I want to talk to you guys about cash cab. All right, who has not read the rules yet? John. All right. The rules. Are you guys listening? Quit shuffling papers. All right. The rules are posted on the announcement page. Everybody has to write 5 questions. You have to cite where you found it, and I want to know what the right answer is. Okay? Last semester, people wrote questions and had the wrong answer, and I couldn't find where they got it. And I was like, well, what's the right answer? And I was like, this doesn't seem right, but I couldn't find it. So, there are 10 points available after you pass all your exams from this, which will help boost your grade. 5 points come from writing test questions, and 5 points come from attending the cash cab and participating and being really enthusiastic. Now, if you don't write questions, you don't get any of the points. All right? So you have to write questions and attend. Now, if you wrote questions and your kid is sick on the day of cash cab, you at least get the 5 points from having written your questions. But if you do both, you get 10 points. So, it is really fun. It's really competitive. Dr. Pink, how many people have met Dr. Pink? He's a scream. He is actually the Associate Dean for Student Affairs. He's the guy that really is the advocate for students, and he is coming to be our cab driver. And he is a hoot. So, I want everybody that can to wear pink. And if you have any of the Love Pink stuff, that would really be good. It's the line from Victoria's Secret. It's the Love Pink. Because he really is a very dynamic man, and he makes this whole game just so much fun. And you guys will, when you come into class, you'll come in and you'll sit in your clinical groups, and I'll call your group, I'll call your group, I'll pull the groups from a hat. We're also going to be doing interactive TV with OPSU, so to help make them feel like they're part of the class and everything, let's make sure we really cheer them on and cheer for everybody and everything. And it's honestly just a lot of fun, and it's a day when we get to be rowdy. But here's the deal. If you write 5 questions and then you look at all the questions everybody else writes, what have you just done? You just studied for the test. Yeah. And then your competitive nature comes out because you want to win something, right? And so there are going to be some prizes available for the winning team. And again, it's just a really fun day. Read your rules. And everybody, that is going to be next Thursday. We're doing psychosis that day also. So we'll do psychosis in the first half, and then the second half is cash cab. All right? Wear your pink. It's going to be a lot of fun. Yes, Miss Ashley? Oh, sorry. Okay. Trying to think what else to tell you. I can't think of anything else to tell you. If you have questions, yes.
So we're posting the questions and the answers on the
Yes.
page?
Yes. But obviously, sometimes people will write a question that's not a great question. So if you don't think it's the right answer, and I highly recommend no matter what question people put up, you look at that page number and you go look up that answer. Because A, that gets you deeper into the material, and B, it, lets you know whether or not the answer was right. Because I'm not checking, I'm checking them as I'm putting them in the PowerPoint, because I'm going to use your questions in the game. It has to come from a source that I can access.
Okay?
Maybe put it something kind of advanced.
You can, but you have to give me the citation for it.
That's fine.
I mean, and I don't need a APA citation. I need Baird, page 162. Okay? I don't need an APA citation. That's totally not necessary. I'm not trying to cause you more work. I'm trying to get you deep into the material so you can learn it. All right?
You're saying there would be questions, the choices, and the answer online. So if you're already telling people what the answer is.
If you're smart, you're going to look it up. Because I'm telling you right now, people put questions up that are not good questions, and people put questions up that have the wrong answer. Sometimes it's a typo, sometimes it's just a misunderstanding, and sometimes it was just the wrong answer. So if you're smart, you're going to look at them, and then you're going to go reference them. Which, when it comes to cash cab, if you miss a question in cash cab, it's not as big of a deal. But it is really going to help you study for the test. So if those answers aren't right, and you got something off of reading all those answers, now I'm not going to put anything up in my cash cab that's not right. Or at least not on purpose. Last year I did have one that was marked A, but it was actually B. But, that was an accident. So, and I did go back and fix that right away. Again, remember I changed your PowerPoint a little bit. So compare what I did today with what you have. And I will get the new one up, and you can either print it off or you can just make notations, okay? Because it's not that far off. I hate to be done so early. Any questions? Nothing? Does that mean I did a great job, or does that mean you don't care? All right. You guys may go.